Welcome everyone to this webinar on GLP-1 based therapies and nutrition. So this session is designed specially for nutritionists and people like you who want to understand the clinical evidences behind these increasingly important medications. And you will keep on getting patients from, who are on these kind of drugs. So you need to have a little bit background and understanding of about these medications. So therefore, we'll start with just the basics that what these drugs are, how do they work. We look at the clinical evidences. We'll explore some nutritional challenges, and then we will look at some practical strategies that will help you all for an effective counseling. GLP-1 agonist. These are medications that copy the GLP-1 hormone in your body, which your body naturally makes it otherwise in the small intestine. Now, what does this do? It actually regulates your blood sugar, appetite, digestion, and also called the incretin mimics. That is GLP-1 receptor agonist or the GLP-1 analogs. So the first approved by FDA in 2005, which was then researched, and there is still a lot of research going on in this area, and therefore we need to understand a little more of what is happening about it today. Now, the GLP-1 agonist, they work in four mechanisms. One is they stimulate the insulin release, the drug signaling, especially to whom? The pancreas, to produce more insulin when the blood sugars rise, so helping them to bring down the glucose level. They also suppress the glucagon secretion, that is, it blocks glucagon, which is a hormone that normally raises blood sugars and prevents any unwanted spikes. Also, it delays the gastric emptying. It means that there's a slow, quick release of food does not happen throughout the stomach, which means that the glucose also that enters the bloodstream is very gradual, and there is small amount of sugar hikes. Also, there is an enhanced satiety signals. You feel full for a longer period of time because there is a natural signaling that's happening, okay, which reduces the appetite and the food intake. So let's see further what we have. Now, these four main FDA approved GLPs are semaglutide, that is, they come in three formulations. Ozempic, mostly for diabetics, Wegovy for weight loss, and Ribelsis. It's an oral tablet. The patients can choose either a weekly injection or a daily pill depending upon what their doctor wants to prescribe for them. Speaking to an endocrinologist is very, very essential here, because I know I have heard a lot of prescriptions that are happening everywhere. Okay, and people should be educated that they should go to the right sources for the prescription. And our role is just to look at the drug and its interaction, or the drug and how dietitians can help the patient achieve maximum benefit of the drug. So we spoke about semaglutide. Then there is another one called liraglutide. Okay, also this comes as a daily injection. Victoza is one, and where there is another one is Saxeda. It's a high dose specifically approved for obesity treatment. Then there is Tirzepatide. Okay, now this is a dual action medication that works both GLP and GIP receptors. Now, making this very, very potent, and it is also given as per what the doctor feels around once in a week. Then there is dulaglutide. Okay, so this is once weekly injection. Okay, again for the diabetes management, and that's how these are the different drugs you will see on the prescription of the patient. Now we are understanding that there were some studies and trials that happened before these drugs came into the market. Okay, and the landmark phase 3 trials that are gold standard in clinical research, which makes these results compelling, and they are reproducible. So there is multiple independent trials that were happening, which shows consistency and a very good impressive outcome. Then, when we talk about the phase 3 trial results of different medications, the tirzepatide 15 mg achieved the strongest result, that is over 20% weight reduction in the Surmount 1 trial for over 72 weeks. Then the semaglutide 2.4 mg came as in a second at nearly 15%. There's another one in the that is in the step 1 trial. It ran for a long time, around 68 weeks, and liraglutide, that is 3 mg, showed an 8% reduction over 56 weeks. Now, all medications like the phentermine and the orlistat only achieved about 7.5% weight loss. Okay, so this is a very important thing to note, that all these trials included patients without with overweight or with being obesity, but they were not diabetics. Okay, they were not people with diabetes. So these are obesity indicators, not for diabetes management. And the takeaway is that the GLP-1 based therapies, both the dual, that is GIP GLP agonist, that is tirzepatide, and the GLP-1 agonist, that is semaglutide and liraglutide. Now coming on to the other significant metabolic benefits, the cardiovascular protection. There was a select trial which was a landmark semaglutide reducing the major cardiovascular events in obese patients who did not have diabetes in the first place. And this is huge because it shows benefit beyond weight loss. It also showed an improvement for patients who are having heart failure, like the STEP heart failure PEF showed the semaglutide actually improved the symptoms in patients with heart failure and preserved their EF, that is the ejection fraction, and this condition was very noticeable. Uh, Considering sleep apnea, both basically whether it is tirzepatide which reduced both the frequency of apnea events and how much of sleep quality was impaired, patients reported improvement in this blood pressure, liver health. Okay, and it is not just treating one organ, it was treating multiple organs. And this led to the key findings that the GI side effects are common with GLP-1 therapies, but they are manageable. Okay, and how do we manage it? Because we see about 44% of patients had nausea, there were about 32% had diarrhea, constipation about 23 to 25%, some had abdominal pain, not much, 10%, but still. Okay, now this manageable, they were all manageable by giving adequate nutritional support and proper counseling. So as the doses were gradually escalating, the patients were able to tolerate it, and therefore, you address the elephant in the room. Now, despite of it being manageable, there were some patients who said that I cannot manage the GI side effects, and they are the ones who wanted to drop off the trial. Okay, so the underscore that importance of setting expectations upfront and supporting patients through these initial phases is very, very important. Now, at the most, we are understanding that there are certain aspects which is of a critical concern. The first and foremost aspect is the lean body mass, that is lean muscle mass, which is essential. We know it's essential for metabolism, strength, morbidity, and the overall health. And therefore, we have to understand what is the body composition. Now, there are three approaches to weight loss, and what you can do is you can give a high protein diet, which is most favorable. Okay, and 11% of lean body mass loss and 89% of the fat loss when you're giving a high protein diet. A person could say, oh, I'm taking these medications, I don't want to do a diet, I just eat my normal food. Okay, so if you say, okay, fine, these are the people who will have maybe restricted calories, restricted carbs. Okay, but these are the people who will not have adequate protein, so they will lose at least 25% of their lean body mass. They will lose fat as well. Okay, so weight loss will happen, but then they will lose both fat and muscle. So when you talk about the GLP-1 therapies, it is important to see the pattern. So 25 to 60% of the total weight loss comes from a lot of lean body mass and not fat, and that is what we want to preserve. So the key findings, they come from major trials. That is the step one trial, the surmount one trial, and both of them showed that at least 10% of the mass was lost in 68 to 72 weeks. Okay, and therefore it is important to adequately provide protein, because sarcopenia and obesity is a unique risk, and therefore we emphasize that these patients could be prone to other problems because of loss of lean body mass. So whether it is the weight cycling, or it is the GLP-1 concerns which we have today, we have to particularly explain to the patient that protein is very essential. Okay, so now these drugs have a high effectiveness in reducing appetite. Okay, and therefore they need to be even more intentional about what they eat, because one is their appetite is low, so they should eat the foods that the body actually requires than what the mind wants. Okay, so you patients may want to eat smaller amount, they may just feel satisfied eating just even small amounts of food, but that small amount of food should have energy density from proteins, vitamins, minerals, micronutrients, because that is all a risk. Uh, Understanding that GLP-1 drives significant calorie reduction, even up to 40% when you compare it to the placebo, protein intakes also drop. Okay, and that is where we should say that we need to give adequate protein for these patients. Other micronutrient deficiencies that are seen is vitamin D, B12, B1, folate, iron, calcium, magnesium, zinc. And why this paradox occurs is because people who are obese in the first place, they do consume calorie dense food, but lot of their food is either poor in nutrients, or it is like an empty calories. Okay, plus there are some patients who have a small intestinal bacterial overgrowth, that is SIBO, which also impairs the nutrient absorption. Some of them, to talk to obesity, they also have chronic inflammation in the body, and therefore they are struggling because they are on other medications like metformin, they are on diuretics, they are on acid reflux medication. So while we say that they are taking GLP-1 medication, say Ozempic or Wegovy, this could actually worsen their micronutrient deficiencies, because in the first place they were already deficient. Okay, and this is like a compounding thing, that as it is they are eating less food, and if you're giving them food that does not have these nutrients, it will create more problems. Therefore these nutrients have to be replenished. Also, coming to the GLP-1, the physiological effects, dehydration is important, because if the patient is not even drinking adequate water, the GFR drops. Okay, there's also seen rise in creatinine and potassium for such patients. So give adequate fluid and hydration so that they are able to manage good kidney outputs. Also, when we talk about the evidence that combines medication with proper nutrition strategies, there's always a better outcome for these. Uh, Protein is always the top priority. How much to give? We have learned that 1 to 1.5 grams proteins is given, distributed throughout the day. Also distribute the calories throughout the day. We know the sources of protein: fish, legume, poultry, soya, dairy. All these have to be given adequately. Remember, resistance training is important for these patients. You have to emphasize that along with protein, as the WHO says, that at least 150 minutes of moderate aerobic activity per week, plus resistance training two times a week for adults between 18 to 64 years. So let's listen to WHO, right? Also, with reference to the Jensen study, it shows that people who stopped taking liraglutide and those who had done supervised exercise at least little more than four times a week, they were likely to maintain this at least 10% weight loss compared to the only medication alone. Okay, so the basically when what I'm trying to say is that exercise is a very important. It's always better together. Now, multidisciplinary approach, as we know, initially people said that now that these drugs have come out, you don't need anybody else. You don't need a dietitian. You don't need a physiotherapist. I'm just losing weight with this medication. But that's not true, right? We all know that when you are on this medication, it is medication plus diet plus exercise, and that is the cornerstone of where this medication will actually be of use. So behavioral health, psychological health, and understanding how these therapies work, all these aspects as a multidisciplinary team really will give out a better output for the patient. Okay, so when you look at the research, there are findings that show that if you have a dietitian, that makes a measurable difference. There's a BMI reduction, okay, at least 1.5 kgs, greater weight reduction. If there is a dietitian on board, there's reduction of the waist circumference, and there is evidence that an intervention from a dietitian is a must to improve the markers, the overall markers of the patient, and improve the outcome of the patients. Also start with a comprehensive 5-step nutrition assessment. Start with your screening, body composition, do a BIA, a DEXA, so that you know what is the baseline, and then you can always evaluate and check on what is happening later on. Plan well, monitor. And the key point is that this assessment must happen even before starting the GLP-1 therapy. Most patients who have already started, and then they have nausea, gas, vomiting, constipation, and then they say, oh, I need to see a dietitian. That's not the right way. Okay. So collaborate with your endocrinologist, collaborate with the people who are in close connect with you. Tell them that yes, you plan to put your patient on these therapies. See that they evaluate one dietary evaluation from the dietitian before they start the therapies, because we know where they have started and where they have reached. Okay, and when we are planning, we know we start with zero point 0.8 grams of proteins. Okay, increase 1.2, add fiber, add hydration, add micronutrients. Even the Mediterranean diet or the DASH diet works very well. If some people want to be on meal replacers, that is also very good, because there is consider recommendations of meal replacements, especially in the early months of the treatment. This clinical trials, such as the direct trial, and the look ahead trials, have shown there is an improved weight loss outcomes, especially for patients with type 2 diabetes. Okay, the rest you have to explain to the patients to eat slowly, eat smaller portions. We can do an entire class on how to eat, what to eat, like low fats, low spicy foods, so that the GI symptoms are, the triggers are controlled. Those all we can do. We have many other classes which will be covering that all, but these are the basic information which you need to understand when you are meeting a patient who has this. Also, medication adherence is very, very important, because I know it's expensive, and therefore people also try to manage it themselves because of the GI side effects. Their cost is an issue, plus they have insurance barriers. Sometimes they're too tired of taking so many medications. They have like a drug fatigue. So therefore, there is people who are also dealing with weight loss stigmas because they have been gaining weight. A lot of mental and psychological issues that do happen. It is on us to back them and to say that it is not just our opinion. This is backed by WHO and the latest Lancet Global Commission guidance on how obesity should be clinically defined. Okay, and that's also very, very interesting. Now, the patient definitely has to have consistency in their lifestyle, whether it is sleep schedule, screen time, monitoring eat any kind of an eating disorder, also managing their emotions, their body image, relationship. And whilst we look at the evidences and the guidelines, the OMA clinic practice statements gives us concrete target protein fibers. Then there is other studies. The Almondas et al. In particularly has a valuable information of patients to manage obesity and medications. Full cycle of assessment management. Read it. There are many Canadian studies as well. Then there's a joint advisory from 2025, which says there are certain guidelines where nutrition is a priority where GLP is concerned. So there are many organizations that come together, like the ACLM, the ASN, and the OMA, and the obesity societies to help you out with what the guidelines are. So basically, we have a patient centric approach. We have to do nutritional assessment, effectively manage the treatment, any medications which cause side effects, and help the patients to come out and have a good lifestyle. So just before I could end this, I would just like to say that definitely your role as a dietitian is very, very important for these patients. And uh, there are a lot of studies which have really proved that dietitian counseling has a significant impact on the better outcome of the patient. And therefore, we as dietitians, and your role as dietitian is very important. I'm happy for questions and discussion.